Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today our topic of discussion is about central retinal vein occlusion. Central retinal vein occlusion is the second most common cause of retinal vascular lesions causing decreased vision, and it is quite common in older patients. So today we will have a look at different slides to see its presentation and its investigation and its management. From these photographs we can see that there are extensive hemorrhages. These hemorrhages are occupying all the four quadrants, extensive hemorrhages, and this is a quite common presentation of such patients who have got central retinal vein occlusion. Here we will see that another photograph, we can see the hemorrhages, as I mentioned earlier, occupying all the four quadrants, extensive, plus there are hard exudates, lapid exudates in the retina. This is a typical classical presentation of the central retinal vein occlusion. We talk about the different causes of patients developing central retinal vein occlusion. Usually diabetics, hypertensives, patients suffering from glaucoma, high intraocular pressure, smokers, patients having high lipid profiles, and there are some rare causes. Basically, any condition where there is venous blood stasis, there is a stasis of the blood in the veins, or the inner lining of the veins, which we call endothelium, is damaged, or hypercoagulable state in the blood, they can cause the central retinal vein occlusion. And usually a thrombus blocks it just behind the level of lamina cribrosa, when the vessel and the vein, retinal vein, central, and the artery are sharing a common adventitial sheath. So maybe some pressure from the artery compresses over there. So there are variable causes and hypotheses leading to this central retinal vein occlusion. As I mentioned earlier, that even the glaucoma can cause it. So basically, as we have seen a patient, when it comes to us, very important for us is to decide that it is ischemic or non-ischemic. The ischemic central retinal vein occlusion has got poor prognosis. How we can differentiate? First thing is visual acuity. In non-ischemic, visual acuity is better than 20 by 200, while in ischemic, which is the aggressive form, it is worse than 20 by 200. The second thing is to look at the pupil reflex, that is relative afferent pupillary defect. In non-ischemic types, there is mild to no RAPD, relative afferent pupillary defect. But in ischemic types, it is quite profound. Also, academically, we go for the ERGs, but that is academic. But from clinical point of view, visual acuity and RAPD are very important. So whenever these patients come, we do examine these patients, and also we have to do OCT macula to see the condition of the macula over there. And I will show you in the next slides how it behaves in such patients. Usually there are two complications. One is macular edema, and the second is new blood vessels growth. So in this slide, we are seeing the macular edema. We can see over there accumulation of intraretinal fluid, thickening of the macula, and cyst-like appearance over there. This is a common cause of decreased vision and it has to be treated. The treatment for these things is the use of anti-VEGFs. We can use ranibizumab, aflibercept, or even bevacizumab to control the macular edema. Very important in such patients is that monthly, whenever they come to us, we have to do, without dilatation, the anterior segment examination and gonioscopy. The gonioscopy is done to see any new vessels growth. The reason is, if there is ischemia, the vascular endothelial growth factors are released in the eye and they can cause proliferation of new vessels in the angle, in the iris. And once they develop, it's quite difficult to handle the situation because these patients can develop neovascular glaucoma. And that's why it is called 100-day glaucoma, because first 90 days are very critical and crucial. Mostly patients develop this neovascular glaucoma, we call it malignant glaucoma, in first 90 days. So what is the solution for these patients? The patients who are developing new vascularization in the eye, if we find, we should straightway go for pan-retinal photocoagulation. The purpose, the reason is that once we destroy and apply the lasers, the release of vascular endothelial growth factors is substantially decreased. While if we talk about the use of prophylactic laser, no, there is no role, no proven studies to do prophylactically. So that's why these patients need to be regularly monitored. So any patient who has central retinal vein occlusion, we should consider to do his complete blood count, ESR, C-reactive proteins, lipid profiles, what is the cholesterol level, renal profiles, his blood pressure monitoring, ECG. So these are the basic tests which should be done in all patients. But if somebody is from younger age group, then he needs, or he has got bilateral involvement, then he needs some further tests, special tests. We can go for carotid Dopplers even for them. We have to monitor the hypercoagulable states, angiotensin converting enzymes levels, homocystinuria. All those rare entities should also be considered. But the most important thing is early detection and management, because if you do not go for the regular gonioscopy, they may develop new vascularization. And 2/3 of all ischemic CRVO patients, 2/3, they develop NVIs. And out of these, 1/3 will go to develop neovascular glaucoma, which is a potentially blinding condition, difficult to manage. So the very important thing is the regular examination of the anterior segment and gonioscopy. Today our topic of discussion was central retinal vein occlusion, its different causes and its management, primarily comprising of use of anti-VEGFs and lasers. And sometimes when there is hemorrhage, vitreous hemorrhage, pars plana vitrectomy can also be done. So I hope my today's topic of discussion will be beneficial for my respected audience in their clinical practice. Thank you.